Okay, on behalf of the PHRN, I'd like to welcome everybody to our Linkage Luminaries webinar series. My name's Felicity Flack and I'm the Manager of Policy and Client Services for the PHRN. I'd like to begin by acknowledging the traditional custodians of all the lands that we're meeting on today and pay my respects to elders past and present. Just some housekeeping to get started. There's a chat box. If anybody has questions that you'd like to ask our speakers today, please feel free to type in your questions at any time during the presentation, but we'll ask the questions after the presentation. This webinar will be recorded and all of you will receive an email to let you know when it's been placed on the PHRN YouTube channel. So today I'm delighted to introduce Professor John Lynch and Dr. Rhiannon Pilkington from the University of Adelaide, who are going to talk about the amazing work that they've been doing in their BetterStart Child Health and Development group. So without any further ado, I'm going to hand over to John and Rhiannon. Thank you very much for coming today.
Thank you, Felicity, and welcome to everybody, wherever you are. I guess our goal today was to try to give you some idea of how we use a linked data platform that we call BBOLD and give you some idea of how it's changed over time. We've been working with this now for nearly a decade. So that's the objective, and Rhiannon's going to lead off with the first section and then I will come back later and finish off. So I'll pass over to Rhi.
Hi everyone, thanks so much for taking the time to join us. I will get straight into it. So thanks Felicity for the introduction as well, but we also wanted to acknowledge that we're presenting from the land of the Kaurna people today and just acknowledge the deep feelings of attachment and relationship of the Kaurna people to country, and that we respect and value their enduring connection to the land and their cultural authority. So as mentioned, we're presenting today on behalf of a lot of our team and our colleagues. So we're in a group called BetterStart Child Health and Development Research Group, and we're a diverse bunch, although John and I are both epidemiologists. And really we all work together in research with the ultimate goal around how can we use data to better improve outcomes for children and young people and for disadvantaged populations in particular. So there's a couple of links there if you want to know a little bit more about us. So this is the BBOLD data platform that we're talking about today. So BBOLD stands for Better Evidence, Better Outcomes, Linked Data, because that's what we're trying to do. We're trying to achieve better outcomes and better evidence. So all of those squares that you can see on the screen there represent different data sources. So we have de-identified data that can follow every complete birth cohort from 1991 onwards, and we can see children during pregnancy, where we see information on their mums in perinatal statistics, and when we can follow them through the health systems, child protection system, the education system, housing, maternal and child health, all the way out into the justice and correction systems. So I think at the moment, our oldest birth cohort's in its late 20s. I think they're sort of hitting 28, 29 in the latest data that we hold. So we've got about 500,000 children at the moment and around 270,000 families. Importantly, we see around 18,000 Aboriginal and Torres Strait Islander children, which is obviously one of the advantages of linked data, that you get to see the whole population. So we know we often miss out on those sorts of populations in cohorts and survey studies. Depending on the definition we use, we've got around 15 to 20% of our population could be described as culturally and linguistically diverse. And we've also got family files created from birth registration. So we worked with SA&T DataLink to do that many years ago now. So we can actually place children amongst their family identified on registrations. Now, we know obviously that changes all the time, but that's actually the best we can do with this data at the moment. And it's probably the best that anyone can do when we're talking whole of population data. Just a few other things I wanted to point out in that the way this linked data platform was designed before I was around, so about 10 years ago now, was that it would include birth cohorts. But you'll notice I didn't say it was every birth in South Australia from 1991 onwards. So that's because the platform actually is based on all children who appear in any of the service data in South Australia. So that's important, because if you want to start working with policy and you want your data to reflect what they see in their own government systems, you need to think about it like that. There are, linked data projects that are based on birth cohorts, so only born here, and there's nothing wrong with that, and there's huge value in that. But I think if you're thinking about reflecting what services see, you need to think about how you design that project too. Family files. So the reason why that's so important for the work we do in terms of working with policy is if you think about improving outcomes for children and you think about early intervention, well, actually, often we're working with families as the unit of intervention. So when we're talking about early, there's not that often where we're working directly with the child. So being able to actually come up with population numbers, prevalence, incidence for families, not just for children, has been really central to how useful we can be in our policy partnerships. I think we were also possibly the first linked data project to add Centrelink data. So we worked with the Department of Social Services a couple of years ago, and AHW is the guinea pig on this. And we're really looking forward to our first paper coming out soon, looking at the welfare experience of children in South Australia. So I've touched on this a little bit, but you'll gather that we work a lot with policy folks in South Australia, and we found ourselves doing all sorts of different activities over these years that we never sort of really envisioned, if you like. So that ranges from descriptive epi through to formal risk prediction, through to thinking about how you can deploy quasi-experimental studies in linked data to understand intervention effectiveness. We've spent a lot of time on returning data to source. So I guess one of the lessons we've learned is it's so worthwhile spending the time to engage with the frontline staff who actually collect and input the linked data that we then go use to tell stories about children and families. We've also spent a fair bit of time with various government departments talking about what should we be collecting. It's a sort of age-old saying that you've got this much data, but you really need this much. So a lot of these administrative data systems have developed over time. And, there are legitimate questions to be asked about, well, what do we actually need to be collecting to inform service delivery and research? And are we missing some? And are we collecting information we don't actually need? So speaking of those partnerships, this is just a bit of a picture that shows you all the different agencies we've worked with over the past 5 years. And also that actually the governance surrounding a platform like this is quite significant. So we've got over 17 data custodians now. We've got 5 ethics committees. We work with both SANT DataLink and AHW as data linkage authorities. And we invest a lot of time into all of these partnerships. So we run a model where we work with our policy people and we try the best we can to actually respond rapidly to their requests. So we know the policy cycle is usually very short and they'd like the answer yesterday. So that requires a particular way of working, which we're not necessarily set up to do in academia. And it takes a lot of time. We've also been working with the Victorian Department of Families, Fairness and Housing for the last couple of years, and I won't go into that today, but of course we're using the Victorian linked data, linked by the Centre for Victorian Data Linkage for that. Another avenue of work which we're lucky enough to be supporting is we've been working closely with Dr. Odette Pearson on how we can use the BeBold platform to operationalise a bit of an example of Indigenous data sovereignty. So there's a couple of links to Odette's profiles there if you want to know any more, but we're actually hoping to realise some funding for that work in the near future so we can actually look at the right of Indigenous peoples to exercise ownership over their data in the truest sense, so a bit of a different governance model and engagement model than to what we're normally used to. This is just a publication we were asked to do. So AHW approached us to write a chapter in Australia's welfare a couple of years ago. The name of the platform's changed since then, but go and have a look if you want to know a little bit more about us. So on to the really interesting stuff, or at least I think so, how we use linked data. So we're epidemiologists, and McGill Rhiannon has come out with this nice neat paper, if you want to go have a look at it, which gives us sort of 3 ways to think about, the sort of types of data analysis we do in epidemiology. And that's how we're presenting the work we've done to you today. So the first one is description. So you could think about population profiles. You know, how can we identify who we might be interested in as target populations for some preventive intervention to improve outcomes later on for children? Then you might move on and go, okay, well, if I know who I want to target, but how can I identify them? And that's where you might think about prediction. So who's at risk? But what do you do once you've identified your target population and you know that this is how you're going to identify them in practice? And that's where causal inference comes in to deform decision-making around what we actually do with that information. So I'm going to start off by just going through a few examples related to how we deploy descriptive epidemiology using our linked data platform. And this first one's looking at the epi of child protection in South Australia. So I just want to reflect for a moment on what we normally see and what we normally know and hear about child protection across the nation. And by and large, that comes from the Australian Institute of Health and Welfare. So they release these actually very informative reports yearly. And what we actually see in these 12-month snapshots is 1 in 33 children across the nation receive child protection services in that 12-month period. We also saw that just over 30,000 children experienced at least one episode of out-of-home care for 2 years or more in that period. So that means they've been removed from their family because of some sort of substantiated maltreatment, and they're now in foster, kin, or some other type of care. So one of the opportunities of linked data projects, when you get access to administrative data you might not otherwise have access to, is to think about telling these stories differently. So instead of taking that 12-month system view, the way we think as epidemiologists is, well, what does this look like over time? So this is just the basic cumulative incidence of notifications to the child protection system for children 0 to 17 years old. And I say basic because this is one of the sorts of questions we ask when we're interested in any problems in research as epidemiologists, but it's not normally done in this field. So what you can actually see here is that bottom line represents children born in 1991. We've followed them out until they've turned 17. And we've seen that around 1 in 4 of those children were notified to child protection by the time they turned 17. Then if we fast forward in time and we look at a more recent birth cohort, so that top line, the orange one, children born in 98, 99, we're starting to get towards 1 in 3 children were notified at least once to child protection by the time they turned 17. So this is big. This is a public health problem. So what if we think about this differently again? So now we're going to actually look at the prevalence of child protection contact by age 10 in more recent birth cohorts. So this is children born 2003 to 2007. And again, we might think of this as a bit of a basic epidemiological question, but this is really bringing the child's view to this as opposed to that system view we saw earlier. So we've followed everyone to age 10, and what we see is that 30% of these children have been notified at least once by the time they turn 10 to child protection. Now we're going to step through the child protection system. 20% or 1 in 5 have experienced at least one screened in notification. So that means that the child protection system has determined this needs to be triaged and investigated further. 1 in 10 children were actually investigated to see if that allegation of abuse or neglect could be substantiated. 1 in 20 children experienced at least one substantiation of an abuse or neglect allegation by the time they were 10. And then when we look at how many children were removed, we see 1 in 50 or 2% experienced at least one episode of out-of-home care. So this life course view that we've taken using this data starts to give us quite a different story than what we see from the system view. But you can also take other things away from this. So we can go, okay, well, this is how many children had those types of experiences in child protection. But actually about 75% of each birth cohort were identified in the system. So you could think about this as a red flag, saying there's actually something going on and we might need to support this family. But really the system has had no formal response to that family. So you could flip that and say, well, we know who those children and families are. So is this a prevention opportunity? So we've got this system view where we see 1 in 33 children receive child protection services in 12 months. But when we've used the administrative data to take a children's life course view, we see it looks like much more 1 in 3 children. So these are complementary messages and they're both useful, but I think when we're using administrative data, at least we've been using it in a way that's been able to give our policy partners a different lens on these types of experiences for children. So now I'm going to move on to another example. So we were working with a directorate called the Early Intervention Research Directorate for many years. We're still working with them now. And they were formed after the release of a Royal Commission into Child Protection in South Australia. So they approached us and said, you know, we're interested in this idea of young mums. So, you know, there's a long history of concern about young mums in the US and the UK. And they were thinking, you know, could this be a target population if we're thinking about preventing entry into out-of-home care? And we said, okay, well, we can use the data to see what we know about young maternal age and out-of-home care. So we know that in the whole population, young maternal age in Australia accounts for only about 4% of all births, although this varies, and in disadvantaged areas, this can go up to as high as 10%. So what we did for our first look at this was say, okay, well, let's have a look at first-time mothers who were aged less than 20 years. And let's follow them forward and see how many of them had children into out-of-home care. I just want to pause and reflect on that for a moment, because we're looking at mothers who were under 20 at their first birth. So this brings us back to the value of linked data. So we were able to use perinatal data here, linked to birth registrations and child protection data, to say, okay, well, even though we're looking at births 99 onwards, we can go back and say, how old was mum at her first birth? Now, this is really important if you're thinking about intervening in terms of early, because the earliest you could intervene, or one opportunity, I should say, for early intervention would be at that first birth, instead of waiting for the second or the third birth. So we're following these first-time young mothers forward in time. And what we actually saw in the data was that 5 had at least one child placed in out-of-home care in the 5 years after the birth of their first child. So we're thinking about young maternal age. We're saying it's 4% of all births, but only 5% of young mothers have children in out-of-home care. So, you know, the policy response is, well, is that a target population we want to think about if we're interested in preventing children entering out-of-home care? But then we use the data to take a different view. So this time we're looking at all children who've experienced out-of-home care. So the unit of interest here now is children. So you'll see we're looking at just over 2,000 children. And I want you to focus on this row, which represents children born to mothers who were under 20 at their first birth. So what we actually saw here was that just under 60% of the children experiencing out-of-home care were born to a mother aged younger than 20 at their first birth. So then that idea of whether this is a target population of interest, if we're trying to prevent children entering out-of-home care, suddenly starts to look very different. But of course, it's really important to notice, and I'm sure you already know this, but it's not about being young. It's not about being young mothers. It's not about being young parents. It's about the confluence and complexity of multiple disadvantages that we see are sometimes experienced in these populations. So we have 1,180 children in this population we looked at who were born to 644 young mothers. And then we use the data to go back a generation and say, well, what could we see about what happened to these young mothers? And we saw just under 70% of them had their own child protection experience, and nearly a quarter had experienced out-of-home care themselves. So we were able to start quantifying that intergenerational story. And you could think about how that might have implications for what sort of service or preventive intervention you might think of deploying. You know, does that need to look different if these young mothers had experienced out-of-home care themselves, as opposed to the young mothers who didn't? So then ED, the Early Intervention Research Directorate we worked with, this sort of resulted in them formally naming young parents as a priority population in their reform strategy. Now, some of the conversations we've had around this work has sort of been this idea, but, you know, don't we already know this? You know, there's a long history of research on this idea of young mums or young parents. And then, of course, you know, there's the old nurse-family partnership, but that was a key eligibility criteria. You know, so what have we done that's any different here? And I think that that sort of has brought us to thinking about how, you know, sometimes what we've done in academic outputs doesn't necessarily help policy find what they need. So for the policy folks, at least the ones we've been working with, the absolute numbers sitting behind these populations that represent your local context that they're trying to deploy these reforms in are what is most relevant. And this idea that they need to consider the demand in full. So how big is this population that might need a service? Because if you think about trying to design and implement reform in this space, well, if we don't know the demand for all of these services from a whole population perspective, how can we actually understand how effective our interventions might be in turning the curve? So if we're only deploying enough interventions to hit 5% of the population, we're not going to be turning the curve on this. And that is, you know, one of the absolute advantages of the whole of population nature of linked data and the fact that it's in your local context of interest. So we can give them these answers. So we have these 644 young mothers and we can use the linked data to characterise them. So who are they? You know, can we think about how we could target these if the primary aim here is to prevent entry into out-of-home care for their children? So if we had an effective non-stigmatising intervention, we could actually know from this that we'd need capacity for about 60 young parents per year to gain population coverage. So that sort of information we think about as an actionable quantity. So sometimes what we're producing in research isn't what we think of as actionable. So I think we have to ask, you know, when we're talking about increasing relative risks or odds ratios, does that really tell the policy side of this story what they need to know? We think about that they need to know where do these populations appear in our service system? So what are the opportunities to engage them? So we can actually see, okay, well, you know, 90% of these young mothers attended antenatal care in their first trimester. So is that an opportunity to engage with them? So this is where whole of population linked data really comes into its own and can help us in ways that usually surveys and cohort studies are not designed to do. So now I'm going to move on to another example of those epidemiological tasks we talked about, and I'm going to talk about prediction. So the first example I'm going to touch on is to do with some work we've recently done with Treasury and Finance in South Australia, working with them and other agencies on the development phase of a social impact bond to reduce out-of-home care. So just in case you're not familiar with what a social impact bond is, I'm not going to go through all of this, but the important thing to take away is that it provides a different funding mechanism to those we're normally used to that enables the social service sector to enter into outcomes-based contracts with government. So that's opposed to what we might be used to, like block funding for programs, for example, where we see that, you know, they're funded for a certain amount of time. So this particular bond we're talking about today is called Newpin. This has been facilitated in South Australia by the not-for-profit Social Ventures Australia, and there's much more information available on this online in this report if you want to go have a look. But this will be delivered by Uniting Communities, and the investor returns on this program are linked to the effectiveness of the program. So the outcome of interest for this program is reunifying children in out-of-home care with their families. So for this particular piece of work, we had a number of research tasks. We had to identify the policy-defined target populations in the data. Now that sounds really simple to say, but in reality is very challenging to do. So, you know, most of you, if you've used linked data before, you would know how it's collected changes over time. So if you're using historical data, you need to do a lot of work to think about how do we actually deal with these changes over time. We're using multiple data sets. How do we bring those together? And for us, we were actually working with multiple agencies. So we weren't just working with Treasury and Finance, we were working with Department for Child Protection, we were working with Uniting Communities here, and we were working with Department of Social Services federally. So we had lots of conversations and lots of work put into how do we operationalise this population of interest in the data, given the constraints of administrative data. The next thing we had to do was estimate the counterfactual reunification rates, and I'll get onto that more in a minute. And then we used the linked data platform to project forward to outcomes that might be of interest in terms of government thinking about savings or avoided costs. So that's things like developmental vulnerability on the ADC, hospitalisations, education outcomes, and so on. So all of this was really designed to actually then put the contracting of this particular social impact bond in a position in that we're as confident as we can be that we've selected the target population and we understand the outcomes for this population in a way that better ensures success. So this is directly pulled from this report. So we did hundreds of analyses for this social impact bond and for another one that we don't have time to talk about today, but not very much of this is public. So like much of our work, most of this is currently cabinet in confidence, but we actually hope to be able to release this in the coming months. So this is some of the work included in the report that came from our partnership with these agencies. So, and the important thing to know here is that that idea of outcomes-based payments or program success is operationalised as the proportion of intervention group children reunified above a baseline or counterfactual proportion. So if we're thinking about outcomes-based payments, how do you know what a good outcome is? Because out there in the world, that outcome might be occurring at some sort of baseline rate that happens whether or not you deploy this intervention. So what we did could be thought about as one of the most basic types of prediction, where you have one state of the population and we're predicting forward just to look at one outcome. And if you just look at that row that I've highlighted there, and if we look at, for those children who'd been in out-of-home care for 6 months at the time of enrolment, their baseline or counterfactual reunification rate was 20% for Aboriginal children and 24%. So then the flow on for the outcomes-based payment is success is only when reunification occurs above and beyond those baseline rates. I also want to point out this. So I know this just looks like a footnote which says this analysis comes from BetterStart, but one of the things we've learned over the last 5 years working with various policy folks, you know, in government and non-government sector is, you know, you spend a lot of time in these partnerships, you produce a lot of work, and often these, you know, beautiful reports come out that get cited, but there's no evidence that actually we've been involved in the generation of that work. So if you're thinking about being involved in this work or that's something you have been, this is the first time for us where we actually negotiated with Treasury, because they're who commissioned the work from us, to actually ensure that if any of our work appears in any public reports, that we're cited, that it actually acknowledges that this has come from BetterStart. So, you know, for us, this speaks to our ability to be able to sort of prove impact, which is, you know, where NHMRC and ARC are going in the grant applications now. So maybe this is something you've all thought about before and other people do automatically, but this was the first time for us that we'd done this. So now I'm just going to move on to a more formal risk prediction example. And here we're looking at how we use the BBOLD platform to predict risk at birth of future child protection contact. So we used data from perinatal statistics, birth registrations, hospitalisations, and we took about 17 characteristics that we know the system can see at birth. And then we predicted forward using logistic regression. In this case, you might use a different parametric model. And each individual then receives a probability of having the outcome, which in this case is child protection system contact by age 5. Now, the underlying, I suppose, concept for this is really that if we're talking about a public health approach to secondary prevention, well, we need to have a way to identify those children and families most at risk before they enter the child protection system. Of course, we don't have too much time to go into it today, but operationalising these models in practice is very complex and is a highly nuanced operation and question. And there are also practical considerations to using administrative data. So if we were to deploy a risk prediction model using the administrative data, what do you do with individuals who have missing information on predictors? Are they just unable to be considered in that operationalisation for this? Does that mean that they can't be eligible for a program? So there are lots of questions like that that need to be asked and thought about if this is going to be deployed in real life. Now we're just going to look at some of the standard metrics that come out of these sorts of models. So here we see the area under curve. That's 0.81. So that's pretty good as far as these models go. So I'm just going to reflect on what that actually means for a second. So an OROC of 0.81 means that 81% of the time, if we were to go out and randomly select a case from the population, so a child who'd had a notification by age 5 and a non-case, a child who didn't experience the outcome, the case would have a higher probability or risk of the outcome than the non-case. So it's sort of going, okay, well, what does that statistic actually mean in terms of a policymaker interpreting this sort of modelling or thinking about how they might deploy this operationally? And then we might look at some of the other standard metrics we think about for risk prediction. So for this example, we've picked the top 20% of children with the highest risk predictions. And if we look at sensitivity and specificity, they're both pretty high. So sensitivity, the models found a bit over 60% of the whole population who have the outcome. For specificity, the models identified just under 90% of children correctly who will not experience the outcome. But then if you flip that, you go, okay, well, actually the models missed nearly 40% of children who will have a notification. So we're not classifying them at risk when we take the top 20%. But we are classifying 14% of them at risk who won't have a notification. So you need to start thinking about what the real life implications of those sensitivity specificity parameters mean. And then we have positive predictive value. So if we're taking this top 20% and we're funneling them into some sort of preventive intervention, what we actually can see from this model is 38% of the children we'd funnel into this intervention will have experienced the outcome. So 60% of that group you're going to target for this intervention in our theoretical example actually won't experience the outcome you're trying to prevent. So then we're talking about false negatives and we're talking about false positives and stigma. So we're trying to prevent contact with child protection systems. So that very first indication that a family might need support. So you could imagine that coming into a program to support families in that instance could be hugely stigmatizing. So what are the consequences of deploying these sorts of models operationally? And also, what does it mean to actually use these sorts of statistics in a policy sense? So we know we could also think about things like the precision recall curve, and that might be more informative than the C statistic. But this is just something we've been working on now with our policy partners. So that's the end of me, and I'm just going to pass over to John to bring us home.
Thanks, Rhiannon. That's excellent. So Rhee's taken us through this way that we think about what we do in these three tasks. The first, I think, underscores the power of good descriptive epidemiology and trying to find quantities that have relevance both in an academic sense, but also in a policy and practice sense. And trying to find those actionable quantities is something that we have found to be useful in engaging and making change in policy and practice environments. And we talked about risk prediction, and we can do that, and there's lots of that we learn in epidemiology. But I think Rhiannon's done a nice job of sort of scratching under the skin of risk prediction, thinking about what is it we're trying to do if we want actionable quantities. You've got to think about things like positive predictive value. I'm not sure a C statistic tells us very much that's policy relevant. So we now want to move on to the third task, and that's what I'm going to walk you through, which is how we have used our BeBold linked data platform to get a causal inference. Causal inference is really all about finding out what works. And that is of huge interest in policy and practice. We want to be able to deploy interventions and supportive programs that work. So, okay, I know how to drive this. Why is that not working? So we're all used to the evidence hierarchies, and the top of the tree is systematic reviews and meta-analyses. Second down is the experimental designs, RCTs. And that highest level of systematic reviews and meta-analyses is done with RCTs. But down here in number 3 are the quasi-experimental designs. Many of you will have heard of this term. They're things like instrumental variables analysis and difference in difference designs, regression discontinuity, etc. And they have been well rehearsed, often used more in economics than they have in epidemiology. But there's a discussion that's happened in epidemiology in probably the last 5 to 10 years, really, it's gained momentum, around using observational data to emulate randomized control trials. And it's something that we've thought about a lot, and we have invested in a lot in trying to skill ourselves up, because this stuff's not straightforward. Some of you will have seen these papers. There are more and more of them appearing. A lot of it has come out of Harvard with Miguel Hernan and Jamie Robbins and other collaborators. And the idea is that we're going to use observational data to emulate a target trial. And some of the examples that have appeared in the literature have been done with registry data and linked data. And we currently have a publication here where we're emulating a target trial of a nurse home visiting program that was conducted in South Australia using the data platform. So we've got the RCTs are the top of the tree, and then you have a meta-analysis of RCTs. Hopefully that meta-analysis is done with quality control of what goes in, because obviously if you put in obviously flawed RCTs into a meta-analysis, it doesn't tell you anything because you're mixing up high quality with low quality studies. We've done a fair bit of work in systematically reviewing RCTs and other studies around early interventions in childhood, not just in child protection, but in other areas as well. And I suppose our reflections would be that there are some problems, some obvious problems if you look through the entire literature. Many of the RCTs are small. By small, who knows what small is, whether it's 50 or under 100, but most of them are certainly what we would consider to be small. Many of them are low quality. They have baseline imbalances, so-called unhappy randomization, and that happens when you have small RCTs. By chance, you will get unbalanced data at baseline, which means the treatment and control groups aren't exchangeable. The other thing we've noticed is that sometimes the populations who are eligible for RCTs don't necessarily match the priority populations that policymakers talk about. And I think there's more work to be done there about matching up our RCT evidence of which populations, what are the characteristics of these populations that get into these RCTs, and how do they align with what policymakers are thinking about as the priority populations for intervention. And that, of course, means we need to consider recruitment. Most of the RCTs that occur in early life interventions are convenient samples. There's no attempt to try to make them representative of a population. They're just convenience, you know, it's the preschool down the road kind of thing. So we need to think about who do they represent in the real world. And retention is an issue in RCTs where there is extensive dropout in some of the early life interventions, the randomized control trials. We then combine that with the idea that we have extensive selective reporting of outcomes. Many of the RCTs that underpin the evidence base for early life interventions do not follow guidelines like Consort. They do not pre-register trials. We have no idea of what most of them don't name a primary outcome. And so when you get the reporting of the outcomes, you get the two things that look good and that's what gets reported, and we have no idea of how many they didn't report. And then you compound that with analysis methods that we're pretty sophisticated methodologically, but when I read some of these trials, I have no idea what they did. So we've got all kinds of problems with the RCT evidence. And this is a couple of years old now, but I wanted to just highlight this. This is not just me having a complaint. Down here, under the Obama administration, they invested huge amounts of money in home visiting programs in the US. And it was all under this comparative effectiveness research funding. But to be funded, to get the funding, they had to be evidence-based programs. And so the Obama administration set up this home visiting evidence of effectiveness. And again, I haven't updated this for a couple of years, but the story is basically the same. And they reviewed all these programs, and they've done a really good job of reviewing the evidence quality. Not all evidence quality reviews are of the same quality, believe it or not. But this is a pretty high quality evaluation of the program. So the first point I want to make is that you've got 19 supported programs, and I can't see what that number is because the thing's in the way. There we go, 25 not supported. And one of the most supported studies we know is the nurse-family partnership down here. So if we just take that as an example. So the first thing about quality is we've got 25 programs over here that are not supported by evidence. 19 are. 19% are supported. So of the 44 programs, only 43% were supported by any evidence. Of the 231 eligible studies, 42% were of high to moderate quality. So the converse of that is 60% of the RCTs in that specific area of nurse home visiting did not even make moderate quality standards. So we want RCT evidence, but in reality, if you review that evidence, we've got some problems with its quality. And if you want to learn more about problems with randomized control trials, then this imposing figure of Sir Angus Deaton is worth a listen to. He's a Nobel Prize winner in economics. And this video box, he takes you through a detailed understanding of what he thinks the misunderstandings of the benefits of RCTs are. Don't get me wrong, RCTs are incredibly valuable. But if we're going to decide what works on the basis of RCTs for early life interventions, most of our evidence, 60% of it, does not even reach moderate quality. So we have the gold standard view for evidence generation. We run an RCT, that feeds into evidence-based practice. And then that is meant to translate into service delivery systems. That can be a very long translational road for all sorts of reasons, from the RCT to the service delivery. When we do that really well, and the nurse-family partnership RCTs are a great model of that, they're very high quality RCTs. When that's done well, it's very informative. We think there's a complementary way to do this that involves using linked data, that we think shortens the translational road and twists this around to talk about practice-based evidence. Here we have evidence-based practice. This suggests that there are innovations going on in service delivery land, whether it's in health, education, welfare, child protection. There are dedicated, clever practitioners altering practices every day. Innovations are going on, and we don't necessarily capture that. So could we run quasi-experimental studies of innovations in practice base that change evidence and shorten that road into service delivery, because they're already going on inside the practice-based systems? So the distance between generating evidence and incorporating into service systems is shorter. And that's where emulating a target trial helps us. And I won't take you through this, the details of this. This is sort of, if you've not heard of this approach, it's worth having a look at. You think about eligible populations, you think about a baseline, you think about how comparable the intervention and the no intervention groups are, and how you make them comparable. And that can involve inverse probability of treatment weighting. That's the old propensity score type thing some of you may have already done, or the more modern way of doing these things with targeted maximum likelihood estimation. And these are explicit and transparent techniques to adjust for confounding at baseline. And the advantage of using administrative data is sometimes you have less loss to follow up. And that can be much less in the RCT, especially if the outcome's routinely collected, like an AEDC, where we get that on the whole population, or a NAPLAN, or child protection records, etc. But using quasi-experimental designs based in linked data imposes additional data requirements beyond what we usually see in administrative data. So we need great thought, care, and extra work that can be required before the intervention is rolled out, so you can make sure that the right scope and scale of information on eligibility, timing, program participation, program dropout is being collected as part of the innovation in normal service delivery. And that means you've got to be in the room. So as researchers, we have to be in the room with the policymakers and practitioners when these decisions are being made, so that we can sit alongside and try to ensure that high quality data is being collected through administrative systems that help us get higher quality evidence generation of intervention effects. And that, of course, many of you know, means building trust. And the stakeholders, spending lots and lots of time with stakeholders and demonstrating a genuine willingness to engage. And we fully understand that some researchers may be unwilling to do this, and that's partly because our academic reward systems, they're not aligned with doing research in that way. But nevertheless, it's something that we can think about as a fruitful use of data that the public has already paid to collect through administrative systems, and can we use it in these more innovative ways. So if you had an intelligent information system that was designed to build evidence-based practice, you would collect information on the processes that occur, the service delivery things like referrals, things that we talk about like warm handover. So often in administrative data, we will see referred to tick, and that referral simply means somebody has made the referral. We have no idea if it was taken up. We have no idea if the family or the individual actually received it. So that's what we mean by, was there warm handover? Can we confirm on both sides of the referral that that happened? And indeed, how much therapeutic contact there was. What was the dose of the services they received? And then the third pillar is, of course, getting data on outcomes. So if we can bring all those things together, then we've got a capacity to do quasi-experimental evaluation of innovations in service delivery. And they can be innovations in government systems, but they can also be in non-government organisations, a vast array of services delivered by NGOs. And one of the things that we're doing in the platform now is we're working with a couple of different NGOs, and their service data that's about referral and therapeutic contact is being brought into our whole of population administrative platform to do exactly these, to try to set up quasi-experimental evaluations of innovations. So we'll finish up with these ideas. We talk about a linked data platform, but we really think about it in sort of 5 parts. The first 3 parts down here are the big data platforms. And that's where we've got our whole of population jurisdictional data from South Australia. We bring in federal data like AEDC, Centrelink, MBS, etc. And you can bring in data from NGOs, or there can be enriched phenotypes from cohorts or special data collections. We're just bringing on board the trauma registry from the pediatric hospital here. So we're collaborating with a bunch of trauma surgeons who want to understand what happens in the longer term experience of children who come through their service and they're as trauma surgeons. And the idea is these 3 sorts of things talk to each other, so we can see the same individual and family in all 3 types of data that underpins that. And that's where our big data descriptive and predictive analytics sits. But up here, we can also think about testing the effects of interventions and doing causal inference. And we can do that We can do that through quasi-experimental evaluations, and we can do that through pragmatic RCTs. So this is a use of a platform around evaluation and innovation testing. So for quasi-experimental things, we know who gets a new service and who doesn't, and then we try to do our best to create exchangeable treatment control groups and do a quasi-experimental evaluation. And then we can see the outcomes down in the other parts of the data platform. If we're lucky enough to actually convince people to run something as a pragmatic RCT, and we've done that once or twice in South Australia, then we can actually randomise people to a new treatment and a control and see their outcomes further down the line. So our experience overall, when we started this about a decade ago, we had no idea of the different sorts of research we'd find ourselves doing. And we've come to understand that there are many types of important research that can be done using linked data platforms like this. And it means we've had to do a lot of learning on the job. I don't think anybody in our group of multidisciplinary colleagues in psychology or criminology or epi or public health were trained to do what we found ourselves doing. We were trained around surveys and cohorts, but using linked data in the ways we use it, we've had to do a lot of on-the-job learning. But we're all driven by in the end, we think epidemiology has to be useful. And sometimes the most useful things are simple, but they're still based on the basic ideas of descriptive, predictive, and causal epidemiology. And we think the BBOL platform has substantively and objectively informed policy, practice, and service delivery in South Australia. And we'll finish there. Thank you for your time and attention, and we're happy to take questions if there are any.
Thank you, John and Rhiannon. That was a fantastic overview of the enormous amount of work you've done over the last 10 years. So we do have some questions. There's several questions actually about the data that you use. And perhaps you can start with just clarifying whether this is a non-consented cohort.
Yeah, that's right. So the process for this linked data platform and most others is that you apply for a waiver of consent through, in our case, multiple human research ethics committees, because it's not practical to be able to go back to, you know, over 500,000 children, etc., for consent. So this is de-identified, and there are many privacy protecting measures in place through the process of data linkage that occurs through the third-party data linkage authorities. So we never see names or other identifying information that would let us ever know one particular individual.
Yeah, and this is exactly the sort of infrastructure that PHRN has supported for a long time to get over this issue of consent and have privacy protecting principles that allow researchers to receive de-identified data. And I just point out that this is 27 birth cohorts in here, so it's not one. You have to think about when you're adding data all the time, we get new birth cohorts as they come along. So we're currently at 27 birth cohorts in the platform.
Amazing. And related, could you talk a little bit more about the cohort and which people would not be included?
So I guess, you know, we start to miss people, if you like, once they leave South Australia. So we only see South Australian service interactions. So we capture the whole population, the whole birth population. And then, for example, if that family leaves the state soon after birth, we won't see them in any other data source. Whereas conversely, we see, for example, 20% of children who have contact with child protection are actually not born in South Australia. So we don't see their birth information, but we do see their interactions with the child protection system. So I think, you know, the sort of idea of what we don't see goes both ways, but we've tried to design the platform in such a way that it reflects as best we can how services are delivered and to who they're delivered to in the state, because that's what it's designed to inform now.
So when we say whole of population, of course, it's It's not really the entire population, but it's pretty close. And it's probably a hell of a lot better than the people that agree to appear in a survey about who gets in and who's missing and who's not. Nevertheless, it does raise missing data problems and how you handle that. And we follow that literature pretty closely. One of the PhD biostatisticians that works with us is a bit of an expert in that, and it's a moving feast. So we do the very best we can in terms of dealing with missing data, but that field is a very, very complicated beast.
Sure. And just to finish with another data question that is much more simple to answer, do you have Commonwealth MBS and PBS data?
We've recently got funding to add it, so we're going through the process literally now to start adding MBS and PBS data. And I did just want to revisit the earlier question about consent, just to clarify, because I've seen the question now written, and we are working with NGOs around particular services, and for some of those NGOs, they do have consent processes in place, and for other NGOs, they are putting consent processes in place. So I guess, you know, we are moving to a point now where we'll have a platform which is a mix of consented data linkage and a mix of, you know, a waiver of consent's been granted.
And for those out there who are researchers, of course, you know, because this is an updatable resource and we add new data, let's say like MBS and PBS, the reason we're able to do that is because we have to get research grants to do it, and we have to keep doing it. So I think in the last month or so, we just paid about $150,000 in linkage fees. And that's a real challenge for an enduring platform, is how you sustain it, add data and add birth cohorts, given the difficulties that we all face in NHMRC or ARC funding, etc. But it is an ongoing challenge to keep supporting the basic platform, which is bringing in new data.
Okay, next question. In the context of risk prediction, how do you prevent this being deterministic? Are there ways to ensure that those with the combination of the 17 characteristics which would predict social services notification are not sucked into the system due to higher levels of surveillance? And it goes on.
Yeah, that's a really good question. So we've done some work on, you know, what you've referred to as surveillance. And, you know, we do see, I guess, you know, upticks in notifications for populations that have higher levels of contact, whether that be with health services or, you know, when they hit the education system, or they might engage in an intensive family home visiting program, for example. So I guess in the context of risk prediction, though, I think those are the sorts of questions we're really raising. So we're saying there are a whole lot of things we need to think about before we think about this being operationalised. I mean, we've seen examples of risk prediction models being deployed elsewhere, and they've been pulled pretty quickly. So in New Zealand, they deployed one, I think it was about 5 years ago now, as part of their sort of, you know, social investment portfolio, etc. And it wasn't too long before a new government turned up and the minister said, we're not doing that, because there was that deterministic identification of native populations such as the Maori, for example. So I think that's one of the questions that has to be asked. I don't have the answer for how you prevent it in this time anyway.
I think the reason we bring it up is because we think it's a legitimate role for researchers to actually sort of lift the veil. It sounds so simple. Oh, we'll just get a risk prediction model and we'll target some group. And you can do it. And that's what Rhiannon showed you. We can get an area under the curve at 0.8. But that's not the real story. And I think it's legitimate for us to ask about how that, I think as the questioner asked, people get sucked into a deterministic system, how the things that are used in risk prediction models can be racist. They use information in ways that mean you get more or less sucking into those systems. So the reason we bring it up is because we're actually really skeptical about the value of risk prediction. And I think we need, in the general early intervention space, to have a collaboration of researchers who are saying, hang on, let's have a think about how you actually use these things in practice, because there are many downsides to it.
Okay, now we're getting close to time. Are you happy to answer one more question? We will send you the rest of the questions so that you can deal with those out of session. But a sort of related question, given the availability of family data, have you implemented or thought of implementing familial risk into individual risk prediction due to the fact that some conditions and inequities are clustered in families due to genetic and or shared familial factors, and how feasible this approach would be to implement in real world data?
The short answer is yes. You know, it's sort of like, well, what best predicts future contact? And the answer to that is past contact, and that's often true for the family level also. So, you know, we've looked at that in the child protection examples we showed today. In terms of that idea of how feasible it is to implement in practice, that's when you start running into challenges, because most of these administrative data systems didn't start until, you know, for many, early 2000s. So then you have to start thinking about, well, how complete is my view of that family history? And, you know, so if we're looking at, you know, children born in 2010, for example, and the data starts in 2000, well, we can only see family history for 10 years. So I guess that's one of the considerations we've had to think about, even in sort of, you know, generating these more academic examples of risk prediction and intergenerational experiences of many types of exposures.
Sure. So I think we'll wrap it up there. Thank you so much to the two of you for a really fantastic presentation. I'm sure everybody enjoyed it immensely. Just to remind the audience that we have recorded this webinar and that will be available on our YouTube site shortly. We'll send you an email when it is. And also to remind you that our next presentation will be by Professor Julian Troller on the 13th of May, and registrations will be available for that shortly. So thank you once again. Fantastic, lovely to hear from you. And
thank you.